All right. Good afternoon, everyone. Welcome to our next Boosters and Beyond Addressing Key Challenges series. As you know, we've been going through the CDC's core infection prevention and control practices for safe healthcare delivery in all settings. This week, we're going to be talking about transmission-based precautions. We have Leslie Morrissey here to talk about that. But before we get started, I just wanted to give a reminder of who we are. We are the IPRO QIN-QIO. IPRO holds the federally funded Medicare QIO contract for the 12 regions shown here. IPRO specifically helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are 3 organizations under the IPRO QIN-QIO banner. So if anyone asks if you know who IPRO is, or Health-Centric Advisors, or Clarent, you say yes. So just to give a little bit of an update with COVID-19 vaccine and boosters, we are seeing an update with the bivalent boosters slowly ticking up. XBB strain continues to be the dominant strain. We'll take whatever we can get with these bivalent boosters. We know that you've all been working so hard to continue to get those rates up. And as you can see with the latest NHSN publicly posted data for the nursing homes, we're continuing to slowly creep up with our up-to-date nursing home residents. And with that, at this point, I'll pass it over to Leslie Morrissey again, who is our speaker for today's topic. Leslie, over to you.
Hi, great. Thanks so much, Josh. I appreciate you asking me to speak today. Do you want me to advance the slides, or are you going to do that?
I can do that for you. Just let me know when. Okay,
great. So today we're going to define transmission-based precautions in nursing homes, describe the infection control assessment and response program, and identify some gaps in long-term care facilities in transmission-based precautions. So this slide is the CDC core infection prevention and control practices for healthcare delivery in all settings that you have currently been talking about. We're going to be covering transmission-based precautions today. These guidelines for isolation practices you really should have at your fingertips. So Appendix A with the 2007 guideline for infection control practices, the state operation manual talks about transmission-based practices. Also, there is a new QSO 1824 that came out on 3/22/2023. It is important if you're a facility that's doing dialysis, infection prevention is a huge part of keeping patients safe. And so that is the link is there for that QSO. Next slide, please. Transmission-based precautions are used in addition to standard precautions when the use of standard precautions alone does not fully prevent communicable disease transmission. So we're going to use contact, droplet, airborne, as well as enhanced barrier. The type of precaution is depends on the mode of transmission of a specific disease. Some diseases require more than one type of transmission-based precaution. For example, SARS, which requires airborne and contact precautions, as well as eye protection with all client contact. Next slide, please. Standard precautions. Standard precautions are the minimum set of a standard of infection prevention and control practices that should be used in all healthcare workers during the care of all patients at all times in all settings. It's based on the principle that all blood, body fluids, secretions, excretions, with the exception of sweat, regardless of whether they contain visible blood, non-intact skin and mucous membranes may contain transmissible infectious agents. You want to ensure that with standard precautions that your PPE is accessible to use in all rooms, not just your contact precaution rooms, but all rooms, because you're using PPE with standard precautions all of the time. So elements of standard precautions include your risk assessment, hand hygiene, respiratory cough etiquette, patient placement, personal protective equipment, aseptic technique, safe injection, sharps injury, environmental cleaning, handling of laundry and linen, waste management, decontamination and processing of reusable patient care items and equipment. Next slide, please, Josh. So the implementation of transmission-based precautions in regard to risk recognition, you want to make sure that you're identifying the risk factors that increase the likelihood of transmission, such as uncontained secretions or excretions or non-compliance, cognition deficits, incontinence, a private room versus cohorting. So if you are cohorting a patient, you want to ensure that you're doing that with a patient who has limited risk factors. So a patient who doesn't have an indwelling device, they don't have open wounds, they're not immunocompromised. Placing signage outside of the residence room, you want to ensure that that sign is very clear and it doesn't contain any HIPAA information. Donning the appropriate PPE for the appropriate organism is essential. Use and dispose of dedicated non-critical resident care equipment. If your equipment is shared, you want to make sure that you clean and disinfect that equipment with your EPA registered cleaner, and providing education to your residents and families. Who does that? When is that done? Do your nurses on the unit, do they have the ability to be able to just grab education for your staff? Next slide, please. Transmission. So direct contact transmission occurs when microorganisms such as MRSA, VRE, and CRE are transferred to another person by touch. It may occur in common areas in the facility, such as the recreation room, your rehab area, but it occurs most often between healthcare workers and the patient. Indirect patient contact includes inanimate objects. So it is transmitted by clothing, your uniforms, your lab coats, tables, bed rails, the dressings of the environment. So there are certain pathogens that may survive on equipment and environmental surfaces for extended periods of time, such as C. diff can last for up to 5 months, E. coli, 1.5 hours to 16 months. Blood-borne pathogens such as hepatitis can stay alive for up to 1 week on environmental surfaces. Next slide, please, Josh. The World Health Organization has this great infographic on contact, droplet, and airborne precautions. I wanted to just give you the link here. Next slide, please. This is also a nice resource from Australia. It provides a great overview of the different types of isolation precautions, as well as infectious agents, the patient placement, what type of gowns, gloves, and masks, as well as protective eyewear that needs to be used in each type of environment. Next slide, please. Does your staff know when to use isolation precautions, and can they state how different pathogens are transmitted? That's really very, very important. Next slide, please. Contact precautions. So contact precautions require the use of gown and gloves on entry to a resident's room. The resident is given dedicated equipment, so your stethoscope, your blood pressure cuff. It's placed in a private room. When a private room is not available, residents with the same pathogen may be cohorted or grouped together. Contact precautions should be, patients with contact precautions should be restricted to their room and restricted from participation in group activities, even when transport or movement is necessary. You want to cover and contain the infected or colonized area of the patient's body, remove and dispose of contaminated PPE, perform hand hygiene. Because contact precautions require room restriction, they generally are intended to be time limited, and when implemented should include a plan for discontinuation or de-escalation. You want to prioritize cleaning and disinfection of those patient rooms, ensuring that they are cleaned and disinfected at least daily. Next slide, please. Droplet precautions. Use droplet precautions for patients who are known or suspected to be infected with a pathogen such as influenza, which can be transmitted through air droplets by coughing, sneezing, talking, close contact with infected individuals. The droplets are 30 to 50 micrometers in size. When you are the type of PPE that you should be wearing with droplet precautions, you should be wearing a mask. And in addition to standard precautions, includes the use of a face shield and goggles, as well as gown and gloves, if contact with body fluids is possible. Studies have also shown that nasal mucosa and conjunctivae are really very susceptible in regard to a portal of entry for the virus. Next slide, please. Airborne precautions are for pathogens that can be transmitted by airflow. The 5 micrometers, they're smaller in size, and they remain in, the pathogen remains in the environment for longer periods of time, such as tuberculosis, measles, chickenpox, and disseminated herpes zoster. In addition to standard precautions of wearing gloves and a gown, a approved N95 respirator mask fitted for each person working in the healthcare environment and eye protection are also needed. This patient should be placed in an airborne infection isolation room with air filtration that is 6 to 12 air exchanges per hour to reduce the risk of transmission. It's also essential to ensure that individuals are thoroughly washing their hands with soap and water before entering the room and prior to leaving the room. Next slide, please, Josh. The OSHA Academy has a free training. The website is here. It does provide a free respiratory protection program that you can take and receive a certificate. Next slide, please. Contact Plus is, this slide is a really great slide. I like this sign. It's not from the CDC, but it is a good tool for facilities to use when you want to define when you want to use hand hygiene with soap and water, and when you need to use bleach-based products to clean and disinfect your resident rooms. You also want to make sure that you're alerting environmental services in regard to, that they need to use a different cleaning product as they do with C. diff and norovirus. Next slide, please. Enhanced barrier precautions. Enhanced barrier precautions require gown and glove for certain residents in long-term care during high contact resident care activities. So if the resident is colonized or infected with a multi-drug resistant organism, some examples include your pan-resistant organisms, your carbonase, your carbonase producing carbapenem resistant organisms, Candida auris, and other epidemiologically important organisms include MRSA, ESBL, VRE. Enhanced barrier precautions really are meant to be used broadly on all units across your whole facilities, and it's intended to minimize the transmission of multi-drug resistant organisms in your facility. Next slide, please. So you want to use those isolation precautions during high contact resident care activities, such as dressing, bathing, transferring, providing hygiene, changing linens, changing briefs, during wound care and the type of wound care. So the intent is not to focus on residents with a skin tear. It really is for patients who are at risk for acquiring a multi-drug resistant organism. So for example, pressure ulcers or unhealed surgical wounds, venous stasis ulcers. Next slide, please. Enhanced barrier precaution resources. There's a great resource on the CDC website where they have updated it. It was updated in January. They have a pre-implementation tool. There's an observation tool where you can use audits and then put those audits into like an Excel spreadsheet. There's also a letter for nursing home leadership and a letter to families that you can use. Next slide, please. Empiric transmission-based precautions. So if you don't know what a patient has, they have unexplained diarrhea, unexplained respiratory infection. If you don't know what's going on with that individual, you are going to put them on empiric transmission-based precaution. Next slide, please. Hand hygiene. So the transmission of infectious agents require a source, mode of transmission, and a vulnerable host. The most important interventions for preventing transmission of infections, of course, are hand hygiene. So hand washing and the use of alcohol-based hand rubs, consistent with accepted standards of practice. So the preferential use of alcohol-based hand rub instead of soap and water in most clinical situations, except when hands are visibly soiled with blood and body fluids, or after caring for a resident known or suspected C. diff or norovirus. In those circumstances, you want to use soap and water, but alcohol-based hand rub really is best practice now. Project First Line has great education sessions for you in regard to pre-made education. So they have 60-minute sessions, 20-minute sessions, 10-minute sessions. The one on this website is on hand hygiene, and the link is already there, Josh, I think. Next slide, please. Interfacility communication forms. It's really important that you are communicating when your patient has a transmission-based infection. So failure to communicate both before and after transition of care are really cause significant patient harm. Next slide, please. Brown has a health service patient education series. It's an online library of information with a variety of healthcare topics that you can go on and download to educate your staff and your family. APIC has free printable handouts on infections for family and residents, as well as the CDC. Next slide, please. Next slide, please. Some gaps noted in with personal protective equipment. You want to make sure that you have training and competency and validation of personal protective equipment at time of employment and yearly. You want to audit adherence to PPE use and provide feedback to personnel in regard to their PPE use. Again, Project First Line does have some great education in regard to PPE use. Next slide, please. Some gaps in transmission-based precautions. So who can initiate your transmission-based precautions for residents in the facility? Is it done on admission? When the patient gets sick on the unit? Does the sign remain in place until or after terminal cleaning has been completed? Do patients and family members, are they educated about it? Do you have waste receptacles readily available for donning and doffing? Next slide, please. There is a resource of Picnic has developed an educational game to help you train your staff in infection control. This is really fun game played with 8 to 20 staff members. You can download the game parts. You can watch a demo of the video. Next slide. This is some great education in regard to people kind of really like interactive displays, and you can put up signs on your bulletin boards of different infections such as flu and TB, and have the staff walk by and pin personal protective equipment, what type of personal protective equipment are needed and necessary for the type of organism that it is. Also, there are a printout of called the Game of Germs, where it just gives descriptions of different multi-drug resistant organisms that are interesting to read for your staff. Next slide, please. The infection control assessment and response tool. This is this ICAR tool is intended to help assess gaps in long-term care, acute care, and outpatient settings. So the Department of Health will come in and do a audit of these areas in your facility. First, they have you fill out the demographic information. This facilitator guide and assessment module is really great. It has wonderful information in regard to best practices with links to evidence-based documents. Go on it, utilize it for your own facility. And also, like in section 3, there's different observation forms. It's a wonderful tool for you to use in your facility to find your own weakness and gaps and implement interventions or develop a process improvement project. Check with your state health department to see whether or not they are actually coming out and doing the infection control assessment and responses in your state. Next slide, please. One of the questions in the ICAR, they asked about, does your staff know how to, what criteria does the facility use to discontinue transmission-based practices for common pathogens? I just put these resources here for you so that way you can read them. Next slide, please. So one is on C. diff. One is on seasonal influenza. Next slide, please, Josh. One is on discontinuation of practice for SARS-CoV-2. Next slide, please, Josh. And also discontinuation of group A streptococcus skin or wound infection. Also included on here is the decision tool from the CDC for long-term care facilities on group A strep infections. Does anybody have any questions or concerns for me?
Everyone, feel free to come off mute or to put your questions into chat for Leslie. Would love to hear from you if you have anything.
Josh, we've had the question about will the recording be available for reference?
Okay, yep. So Diane, the recording, we are planning on playing this recording again tomorrow at 3:30. So if you know anyone who would benefit from watching this session, be sure to have them check us out for a live replay of this session tomorrow at 3:30. We also plan on posting this recording on our IPRO website for it to be viewed at a later time. And Leslie, I wanted to ask if you would, if you're comfortable with me sharing the slides with the folks on the call.
Of course.
Yeah, okay. So what I can do also is I can provide everyone with a copy of the slides. And that way, if all the links for the resources are in there, there's also a lot of great information on Project First Line that we really encourage you folks to check out. That's really good infection control training. Got a couple more things into chat. Sheila shared it. Thank you. This was very helpful. I would also recommend contacting Project First Line for a facility audit as well. And Stephanie saying
they're really very, very helpful. And it's good to know where your issues are, and they can really go in and do assessments and do audits of things that you might not have the time to be able to do. We historically have not done hand hygiene audits in long-term care facilities, and you know, that's fairly new, but it's so important to find out where our gaps are.
Thank you. We're getting close to the end of our session. If you found today's session helpful, if you could just please put in chat, it would be much appreciated for Leslie and us here at IPRO. We do take feedback in consideration to help inform future presentations. We're about to be at 12:30, so that'll be it for today's session. If there's no other questions, again, if you can just let us know if you found today's sessions helpful on your way out, it would be very much appreciated. Thank you so much.